So without further ado, I would introduce Dr. Pamela Snyder, who's your moderator for today.
Good morning, everyone. Well, it's kind of powerful that most force is gathering downtown while we're talking about least force. Can we have our slides? The first set. Thank you, guys. So yesterday we started with a really easy topic, the metaphysics of vitalism in science. Today, we're going to talk about bridging the spectrum of the therapeutic order, but kind of go really deep into the question that we hear over and over and over from newer graduates or mid-generation graduates is, I struggle to know how to evaluate and manage least force. What is it, right? And we picked a difficult condition, which is actually, for many vitalists, not a difficult condition, but feels difficult, asthma, so that we can use it as a model to start unpacking what are these Jedi warriors? What are they thinking when they're really moving through a difficult condition, and how do they keep the patient safe while they're reducing forceful therapies and treating disease by restoring health? We're calling it bridging the spectrum of the therapeutic order, but it's really bridging the spectrum of force. We're using case studies. This is not a review of pathophysiology of asthma, except for one slide on a naturopathic perspective. This is meant to be a clinical discussion. So what we're going to do is each of our panel members are going to present on the least force, what it is, for 1 minute. It's going to be like speed dating with the force. And then they're going to each go into an 8-minute presentation on how they evaluate and manage along the therapeutic order through assessment, the sense of assessment. How do you keep the patient safe? How do you reduce force? When do you need to scale up? So that's what we're going to do. And then after that, and for 15 minutes at the end, you get to engage with the panel and explore, what are you guys thinking? This is how I do it. Okay, so I'm going to introduce everyone. Can you switch? Oh, I'm supposed to switch slides. Okay, so we have the panel bios up. Intentionally, we're going to only introduce our members who are all eminent clinicians and leaders in the profession who actually represent the spectrum with their clinical titles. Dr. Tish Cronenberg. Dick Cronenberg is the director of Windrose Naturopathic Clinic. Jared Zeff is the medical director of Salmon Creek Clinic. Bruce Milliman, the director of Nature Cures Clinic. And Jaquel Patterson is the director of, you're going to have to remind me.
Fairfield Family Health.
Fairfield Family Health. What's important about this is that the goal is that we focus on the clinical evidence. What is it they know? How do they know what they know? And how are they applying the wealth of vitalistic knowledge in their practice so you can be more empowered as a clinician? So before I mention the goals, this talk grew out of another ladies' room conversation, wherever our ladies are. One of our panel members. But it also grew out of a query we had in the Foundations Institute, which was as we were pulling together an asthma monograph on the therapeutic order, we're very therapy heavy. Where's the assessment? How do you move from one level to another? How do we document? How do we codify that? So I chose Bruce and Jared, Dr. Milliman, Dr. Zeff, for an interview, and lo and behold, in the interview, you would perceive them potentially at different ends of the therapeutic order at times, not at all. They had a very similar evaluation process. So part of the goal is to show you that we're more unified than we realize. We may talk about certain areas we're more interested in, but surprisingly, they really went up the force scale in a similar way with a similar evaluation. So we want you to see that. The goals are really what I want to emphasize. You've seen the goals. The goals are that, and we ask you to help bring out that evaluation piece. Think of the younger grads who actually are concerned about how do I stay safe with my patient while I drop them from high force therapies or start low and move high, and how do I know? These Jedi warriors, I've had to nag them. They know, right? But how do we tell you how to do that? Okay? So, intros. We can begin the force slide. We're going to start each time with Dr. Zeff. And in the backdrop is primum non nocere. He's going to talk about what is force. What is least force? Yes.
To me, least force is simply establishing the fundamental basis of health. Appropriate diet, sleep, rest, appropriate exercise, good air, good water, a healthy psychospiritual attitude. That, to me, is the foundation. Then you build on that.
Thank you very much. Hey, Dr. Milliman.
Well, needless to say, I agree with everything Jared said, so I could just pass the microphone. But there may be an additional thought, and that is the force algorithm, the least force algorithm. Is it safe? Is it effective? Is it cost effective? And those are ideas or concepts that I try to keep in mind when evaluating a force level: safety, efficaciousness, and cost. And out of that, the lowest level of intervention.
Thank you, Dr. Milliman. Dr. Patterson?
Agree with much of what was said, and a big piece would be removing of the obstacles. And so, I know in this case we're talking about asthma, so a primary piece, at least for me, would be diet, as dairy, gluten in terms of common triggers with asthma, as well as environmental triggers. So that would be a piece that I'd have to look at, particularly for asthma: house dust, molds, or specific mold types, indoor pollution, especially depending on the area in which people live in urban areas. So I'd be looking at the obstacles first.
Great, thank you very much. Dr. Dick Cronenberg.
Well, the least force is what you need to do to move the patient towards healing. And I'm just going to say less is always more.
Nice, thank you. So they didn't even use their full 5 minutes. More time for us to talk with them. Okay, thank you very much. So now we're going to roll into a case-based discussion. They're going to be using cases and drawing out how do they move from one level to another, not just the therapy and how it works, not just the cause and what the cause is, but what are the signs and symptoms? What about respiratory volume? What about lung sounds, etc.? How do you know? Okay. So you can ask me to use any slides you want, but we're going to start with Jared. So we need Dr. Zeff's slides. It says asthma simple. You guys got those? You got those next slides? They're coming. Okay. So while we're waiting, think about what least force is to you. What do we mean by force? What is force? Okay.
Am I up? Okay.
You want to come up here?
So I wanted to begin with a quick review of vitalism, reiterating to some extent what Dr. Coulter said yesterday. To me, vitalism, very simply stated, is an intrinsic property of living organisms that appears to operate with intelligence, that maintains order and promotes healing. And this is somewhat quantifiable. There's ways to quantify it, but basically it's difficult to quantify. And certainly it's difficult to reduce into parts. We don't know what those are. In this regard, health is the natural state of the organism. That's a nice discussion to have at some point, but not today. For me, in treating asthma, I love it when a mom or a dad brings me a little kid with asthma, because almost with certainty, that kid is going to be breathing without any help in a month or two or maybe 3. That's what I see almost every time, and I want to talk about how I do that. First, I have to get the diet right to reduce toxemia. To me, what drives asthma is inflammation in the lungs. That's coming from toxins generated in the gut. So I have to get the digestion right. I have to find out what's driving that. Usually there's a food, maybe food combination, and I use old Dr. Carroll's method to make that determination. I give the child a diet. Usually they need 5, depending on how old they are, how big they are, 5 to maybe 15 treatments once a day, 5 days a week, constitutional hydrotherapy. I find a homeopathic remedy that can treat the breathing, usually on the first visit. I'm going to give a little demonstration of that in a second. I'll give them usually a botanical lung tonic to promote good circulation, healing, soothing in the lungs. Usually manipulate the upper spine, lower neck, where the nerves come out that go to the lungs, where there's usually some mechanical disturbance, vertebrae out of place, and we just either gently or with a little bit of force put them back into place. And I tell the kids, we're going to make a little popcorn on your back, pop, 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 and we all laugh about it. And then usually they're on some medications, 1 or 2 inhalers, sometimes some other pharmaceuticals. And so the basic instruction is do these things and then use the inhalers as you need to, and I expect to see the use of the inhalers or whatever it is come down. Here's a case to illustrate that. A 5-year-old girl was brought to me. She had a lot of colds her first year. She was breastfed, then put on formula. At 18 months, she had a severe asthma attack, was taken to the hospital. It was triggered by a URI. She was put on Flovent, that controlled things. But every time she got a URI, she ended up in the hospital with severe asthma. So her regimen when they brought her to me was she was on Flovent twice a day, albuterol as needed. When she had a flare, she was put on more steroids. This is what I found. In my assessment, she had a potato intolerance, again, using old Dr. Carroll's method. So I counseled mom on what that meant, how to deal with that, and we have a dietary counselor in our office. We started her on daily constitutional hydrotherapy. I gave her a dose of antimonium tartrate in the office. Instantly, within a minute, she could breathe better. So I knew that remedy was going to work for her. So I sent her home with that in a low potency to use several times a day, and in a higher potency for an acute event. I gave her a botanical lung tonic. I did a little manipulation, made a little popcorn on her back, and told the mom to start reducing the inhaler as she seemed to be doing better. So first week, she was breathing pretty well. She coughed for a few days, that stopped. She didn't need any Flovent. From the moment she left my office, she didn't need Flovent. They were using the lung tonic and the antimonium tartrate as needed. By week 4, she had some mild asthmatic events, but the antimonium tartrate was all she needed to ease that. She didn't need albuterol for that first month. She had an acute shortness of breath episode with a cough at week 6. In my mind, she's having a healing reaction or a healing crisis, we could call it. I gave her some IV cough syrup. Diagnosis was mild bronchitis. She didn't have asthma, and she didn't go to the hospital. And mom said that's the first time that's happened.
So Dr. Zeff, I want to dial in right there and say, when she had the acute attack, how did you make the decision based on what symptoms or what she was reporting, what you were hearing? How did you decide not to go to the nebulizer or go
I
to the
said,
hospital?
first, give the homeopathic. If that doesn't work, use the...
And for how long did you ask the mother to watch her and then call you back?
Well, she used to call me anytime there was a problem, day or night.
Okay.
But she never called.
She didn't call.
There wasn't any
Okay.
problem.
No, that's the question. How long do you wait with a homeopathic remedy? Isn't that a question for
5
many
minutes.
people? 5 minutes. Okay. Thank you. Good.
Or less.
Or less. And call me if it's not getting better. Okay, thanks.
So
It's a Jedi thing.
I wanted to address the assessment. Oh, you're way behind me on the slide. Keep going,
Keep going?
keep going, keep going.
Oh, no.
You're going the wrong direction. Keep going. One more. There, okay.
Great.
So in trying to explain in terms of assessment what I'm doing, First, evaluate the conditions for health. So I'm looking for a dietary cause of toxemia, which is driving the inflammation, which is driving the asthma. I'm looking for an assessment of how vital is the person. Usually kids are extremely vital. They heal fast, they respond quickly. That's not always the case, but it's almost always the case. And I can assess that partly by just giving them a remedy in the office and see how quickly they respond. And I have an example of that in a second. Looking at the systems involved, the physiological and bioenergetic assessment, I check digestive and pulmonary reflexes and get a sense from, in this case, from the parents, how they're doing with diet and digestion. I'm looking at structural obstacles. I talked a little bit ago about the spinal vertebrae and the lower neck and upper back, looking for misalignments. I use a peak flow meter in asthma cases to see get a baseline when they first come in, blow into this thing. Let's see what the peak flow is, record that. And then I can use that to follow the case. And then do I need suppression? Now, almost in every case, the asthma kids are already coming in suppressed. They're on pharmaceuticals already. So that's not something I usually need to decide. But the general instruction is continue doing everything you're doing, continue with the medications, use them as needed. I expect to see less use, and we'll see what happens. So I need to know, is this something that I can heal? Is this something that's going to require long-term suppression? But in a kid with asthma, my experience is this kid should be able to breathe without help fairly quickly. Here's a little example. This kid came into my office Tuesday, 3 days ago. Chief complaint of allergies and asthma. He's 8 years old. He blew 140 on the peak flow meter. Should have been around 300, given his size and age and everything. Now, mom says, this kid, he eats salt right out of the salt bowl. With a spoon. I'm thinking, now, does that bring a remedy to anybody's mind? Okay, so I gave him a dose of Natromur just to see what happened. And then in a few minutes, I had him blow in the peak flow meter again, and he went from 140 to 250 within 10 minutes. So I knew that was a good remedy for him. So I sent him home with, in this case, Natromur 30C to use as needed. I took a little blood sample. The next day, they got from me by email some dietary advice with instructions to call if they needed any explanation, and she was going to start hydrotherapy, in this case at home. And I'll see the kid in 2 more weeks and see where he is, but I already know where he is. He's breathing better. I've talked to the mom.
Thank you, Dr. Zeff.
The Natromur is working well.
That's a great example of the kind of decisions that need to be made with the peak flow meter. So thank you so much, and thank you for the sign. Now we're going to move on to Dr. Milliman, and that means we need to go back to the original slides. Thank you. Great. Yeah. Which one do you want?
Yeah, the next slide. Looks like this.
This one?
There we go. I don't know whether people can see that or not. And I hope I haven't offended anybody by boldly making a diagram, because I do believe a picture's worth 1,000 words. And you can see we each have a computer. This is mine. I'm looking at the same one the same picture that you are, my cheat notes. But because I have it memorized, I'll put it down. I want to share with you a case that it will illustrate what I hope I can convey in maybe 4 minutes. And that is an infant between 1 and 2 years old, presents with a fever of 104 degrees, I don't like the word asthma, so we'll say breathing asthmatically. And that fell on the heels of a pneumonia, which is probably the cause of the fever. I, at that stage of my career, was a colleague of Dr. Basture was still alive. Actually, they went to medical school at the same time. His name was Quance Crawford. And I took advice from Dr. Crawford and presented the case to him. And he sort of, he's looking me in the eye and said, "When's the last time that baby pooped?" And I'm appalled, right? I said, Dr. Crawford, the child has a fever and pneumonia and asthma. And he said, "When's the last time that baby pooped?" And it turned out that it was about 3 days. And he said, "So, do you have any senna syrup?" And I said I did. And he said, "Well, give the baby a teaspoon of senna syrup." And I did. And to make a long story short, by the next morning, the baby had pooped.
Yay.
Right? There were a few more doses of senna syrup in there, and on examining the contents of the diaper, I thought, as a clinician, oh my God, the intestines are in the diaper, right? Because there was no poop, and it turned out it was about approximately 16-inch long Ascaris lumbricoides worm, and we have I'm keeping an eye on this young woman down here. We have a Brit, a Frenchman, and I believe an American. It took them something between themselves 150 years to completely define the life cycle of Ascaris lumbricoides, which I think probably just about everybody in this room knows. The gravid female's eggs have to pass out of the body and into the earth in order to become infective. And then, kids play in the ground, and we have pets, and pets are vectors, and so on. I'm saying this because if you, instead of looking at me, look at my beautiful picture on the screen, you'll see that I use the term down by gut, down in the lower right, disturbance. Because the disturbance could be a toxin, it could be any other antigen-generating entity, including but not limited to both helminths and other types of worms. The organisms pass from the gut into the portal drainage, and then we all know where the portal drainage goes, right? It goes to a capillary bed in a very large gland organ called the liver. And if the antigen barrage, be it from toxins, from chemicals, medicines, Ascaris lumbricoides, as you know, when they navigate their life cycle, this is what the Brit, the Frenchman, and the American figured out finally, that these incipient worms pass into from the liver if their liver's overburdened and overflow. And then what happens? They go to the next capillary bed in the pipeline after going through the pump, through the heart, and they burrow out of the alveoli into the bronchioli and travel up the bronchioli into the bronchi and so on, and finally wind up in the mouth, at which point we you saw my Adam's apple go up and down, swallow them, and these now viable creatures are able to start this whole cycle again. So I think that the take-home is that as far as asthmatic breathing is concerned, there will always, I will stand by that, and I think all of us will stand by, there will always be an underlying cause for an antigen barrage or an antigen overload that will trigger this process that we call asthmatic breathing. And our real challenge is, while we're, as Jared has already said, keeping them safe perhaps for a little while, almost inevitably, both the types, steroids or bronchodilators, the frequency and the duration of need to use these things will diminish. if we are successful at addressing the underlying cause, and we're good to go. And I'll reserve any additional time I might have, which I understand is 2 minutes, but I'm so proud of myself. These computers are inhackable, right?
Right?
I also like paper charts. Just to say, call me old-fashioned, but the only way anybody's going to get past HIPAA with me is over my cold, dead body.
Spoken like a true naturopathic rebel, right?
And I yield to my
Dr.
colleague.
Patterson, thank you, Dr. Milliman. Great case. Dr. Patterson.
Okay, thank you. Could we pull up the therapeutic order?
Sure.
That slide from
Yeah.
earlier. Okay.
Thank you.
This must have a low battery. There we go.
Okay, there we go. So I have actually even a little less than Dr. Milliman. I don't even have a picture. I just have my notes here in the front of me. So I guess I'll speak a little bit about my process and something, I guess, from a different angle than might be talked about in the panel. The biggest piece I initially look at, firstly, I'm also an asthma sufferer, so the biggest piece to initially look at are what are those triggers. So for me, it's specific heart rate at exercise above 185 and managing those environmental triggers and the allergens that I was talking about earlier when we talked about low-dose intervention. But the biggest piece that I'm looking at is the classification systems and how I have a patient go back further in the scale. So there's 4 different classification systems for asthma. So there's mild intermittent, mild persistent, moderate persistent, and then severe persistent. And they all have different levels of acuity. So an individual with mild intermittent asthma would be someone like me who has asthmatic issues occasionally. It would be less than 2 times per week. And there's different FEV rates depending on those classification types. So mild intermittent would be an FEV greater than 80%, as well as mild persistent. But the frequency in mild persistent individual with asthma would be a couple times a week. Moderate persistent would be daily, and then a severe persistent asthmatic would be throughout the day. So typically I see when those obstacles to cure are removed, do they change within that classification cycle to find out is that where the root of that issue is occurring. And if that does not change it, what are the other areas that we're going to look at? And at that point, I'm going to be looking at the immune function, GI functioning, and trying to move them back more towards like a mild intermittent. Oftentimes the patients we're getting in my practice, it's about 30% kids, and often the percentage is typically focuses on allergies. And so we often do in our office what's called sublingual immunotherapy, which is after allergy testing, and that's typically food removals. And what I find for the children we have with asthma, the most common allergens that we're seeing are dairy, eggs. We have gluten as another really common allergen, and so they'll have to remove those foods for pretty much about 8 months, as we do what's called the sublingual immunotherapy drops, which they do every day to decrease their sensitivity. And over time, actually, after they finish through that protocol, most of them, I'd say about 95%, can actually have those foods back into their diet. And also, you'll see the severity of the asthma symptoms decrease. And oftentimes, as we know, there's eczema, other skin issues that occur with that, which you can see pretty rapidly within 30 to 60 days. So you also want to look that they're now needing to use their beta agonist, short-term beta agonist, less frequently. And then also, if somebody is coming in with a higher severity, you want to make sure that there's proper management. So if someone's having those frequent bouts, you want to make sure you're following up in 2 to 6 weeks until they're getting into control every month, and then eventually protracting that as the intensity decreases. So in terms of the therapeutic order that I begin with, which I mentioned was the bottom line, which is evaluating the condition. I'm trying to bring it up here. And environmentals. And then I'm going to be looking at things like hydrotherapy several times a week, making sure to rule out any specific allergies. I look at stomach acid because that's another piece in terms of reduction of foods that cause difficulty with digestion. looking at fermented foods, probiotics. I have a lot of patients with asthma with really low IgA, so we want to look at the microbiome and how we can increase that. Any kind of food consumption through vitamin A, C, E, that also is going to help with the integrity of the blood vessels. Also, things like fish oils to decrease the inflammation and help with the lipoxygenase cycle. Other pieces I think are helpful, especially with the kids, I try to have them do early on, as breathing exercises and stress management, because those are often the triggers once they begin having an asthma attack. And then I kind of go through the higher levels. So physical medicine is not something I do so much, but that would be an area that I would look to consider as you're going up higher in the scale. And then I would start introducing herbal medicine. One of the things is the beta agonists are great in helping with bronchoconstriction, but they don't handle the inflammatory part. They don't address that part at all. And that's an area in which I think we can do really well in terms of providing care outside of a corticosteroid, which you may have to do if it's in the moderate intensity at some point. So the herbs I'd look at are boswellia, omega-3, high dose, 3,000 milligrams, licorice root. Obviously, you have to be mindful of the blood pressure as well with that. And then I kind of go up in scale depending on the severity in addition to the medication they're on. I will look to help support them in getting off of that over time if they start changing in that scale of classification. And then I wrote some notes on like when to do high force. I don't know if you wanted me to talk about that now. So typically in terms of categorically, I look at if they're tachypenic greater than 25 respiratory rates in a minute, tachycardia of greater than 110 pulse per minute. Obviously, if they're not responding to the inhaler, if they're cyanotic, if their accessory muscles are really extended in terms of due to fatiguing, and then also if they can't say no more than 3 words, so they have difficulty saying words. So at that point, I would feel that that's an acute and imminent situation in which you would have to send them to the hospital to do higher intervention.
Terrific. I want to ask you one question because thank you, Dr. Patterson. One question was you had mentioned forced expiratory volume and vital capacity. Do you use that as part of your scaling?
Yeah, so...
As Dr. Zeff had mentioned.
Yeah, so that's important piece, especially if someone is below the 80% criteria. You want it to really be at least above 80% consistently. So at that point, in terms of with medication therapy, I think is really crucial until they get to the point where it's more stabilized and controlled.
Awesome. So you can see the Jedi and then mid-generation kind of comparison of what we're sharing. I want to say with great respect, I mean, I'm tearing up over this. The docs have been in practice a long time. I was asking them, why don't you say the same things Dr. Patterson is saying about how she scales up? Because what they say is we've internalized it. We're just doing it. We're like in the dance. And I think that's really powerful. And part of what we're trying to do is bridge those gaps in knowledge to actually bring them together. Because we don't evaluate from a completely allopathic perspective. We add that knowledge base to the Vitalist knowledge base. So we're trying to put them together and bridge the spectrum here. Okay, so thank you. Great. Dr. Dick Cronenberg.
Okay, if we could cue my slides. All right. So I want to say thank you very much for the AANP for inviting me to speak this year. It's been a while since I've been back. The high and only mission of a physician is to restore the sick to health, to cure, as it is termed. I want to bring the terminology of cure back into naturopathic medicine's vocabulary. I think we have a fear of not saying the word cure, because most of us, well, I shouldn't say that, many of us now practice in an allopathic model, insurance-based model, and that's verboten to say the word cure, right? Can't say you cure something. So it's a term that's been in our profession a long time. And the goal is to help the patient cure. You're not curing the patient is doing the curing, the patient's doing the healing. But you're opening up that ability for that patient to cure. Because if that isn't in your mindset, if that isn't your goal for that patient, then you're doing a disservice to that patient. You hold that truth for that patient that they can heal, that they can cure their disease, whatever disease that is. So let's bring back the word cure. So first, do no harm. As naturopathic physicians, we follow these precepts, right? Apply the least force possible. The suppression of symptoms is avoided because suppression generally interferes with the healing process. Respect the work of the vis, which is our own innate body's ability to heal. I love this graphic. It helped me a lot because I never can quite remember the order of Lindlar's tenets here. In the trunk of the tree are the things that cause disease. They're influenced by the roots, but the issue we're dealing with is lowered vitality, abnormal composition of blood and lymph, and the accumulation of morbid matter and poisons in the system. Don't forget that. All diseases come from the toxemia. All disease is the same. All disease comes from the same spot. It comes from toxemia. If you know that, then you know what to do for this patient. You don't have to guess. You know what to do for this patient, and it really is that simple. Decrease the toxemia, and that person starts healing. All of our elders knew this. It was part of our medicine. This is the root of our medicine. The therapeutic order here, I'm going to flip this upside down because my slides from a long time ago were made the other way. So we're flipping it here in a minute. So these are quotes from the Nature Doctor book, which I love. Lindlar said, such chronic supposed to be incurable diseases, and I won't list them all, yield to the natural treatment, provided there is enough vitality in the system to respond to treatment, and the destruction of vital parts and organs has not too far advanced. Now that's the art of the medicine, to determine what's the vitality of that patient. Can that patient respond to your therapies or not? You know, and if they can't, then they need to be maintained on certain medications. Some people, you can't get them up to where you hope they can be because their disease process is too innate, it's too ingrained. But you don't know until you try. You have to try because you don't know what that body can do until you unleash its power. Boucher said, the essence of all disease is the accumulation in the system of waste matter and impurities. The elimination of this toxic matter from the body is what nature's striving for all the time. It's through detoxification that the healing latent within all of us can be given a free hand to function. Here's the therapeutic order. I'm flipping it upside down. So the least force is identify and remove the cause of disease with diet, digestion. What's the stressors on their system? What's their spiritual health? What's a healthy regimen for them? Stimulate the vis. And these things overlap, so I don't really know about the order part of this thing. I do them all. So hydrotherapy, manipulation, craniosacral, homeopathy, anything you can do to stimulate that vitality is what you need to do. Whatever is best with your hands. Every physician's different. We all are different healers. We all have different ways we use our mind and our hands for that patient. Support damaged systems. I do that a lot with glandulars. You might do it with botanical medicines. Correct structural integrity. Address pathology, and the last thing is suppress, which I call the cut, burn, and poison method of allopathy. And I've been accused of, I shouldn't say it that way, but it's cut, burn, and poison. That's what allopathy is. And that's the greatest force, right? That's the greatest interjection. So, evaluation of asthma. We're going to do an examination. We're going to check blood pressure. We're going to check pulse ox. Of course, you're going to be smart. You're going to be wise physicians. If this person needs to go to the emergency room, send them to the emergency room, right? Most of the time, people come in controlled on inhalers and steroids, so you're going to be working with that. And as they heal, you need to know how to help them get off those drugs. That's a whole lecture that Dr. Christy Fleetwood and I did at the AANP a couple years ago. So you can look at that. Evaluate vitality of the patient. Now that's various. I do that with blood photography. I do that with heart tones. I do that in different ways you might not do. You can feel pulses. There's so many ways to determine the vitality of that patient in front of you. Determine effectiveness of their current therapies, right? And determine their support network. Does that patient have a support network that's going to help them to heal? Are they in a place where their parents are on board that, yeah, we're going to be decreasing this child's steroids as we're doing hydrotherapies? Or is that contraindicated to their mindset? Is there going to be a grandparent that freaks out and goes, no, you have to, you have to have everybody on board to heal whatever condition that person's having. So with asthma, determinants of health, I always start with the Carroll food intolerance diet. You could do the blood type diet. Anything you can figure out what is that person's inflammatory food and get it out of their diet, because that ultimately causes the toxemia. You can do all sorts of things for folks, but until you remove that toxin, you stop putting the poison in the body, then that person can heal. Okay, you have to figure that out. There's many ways we do that. I think my way is right, but... So regimen, do they exercise? What is their spiritual life? Are they resting? Replete nutrition, and generally with asthma, I find is low essential fats and low vitamin A. Vitamin A heals the lungs, it heals the eyes. And C, of course. And then stimulate the V's. I do that with hydrotherapy. I do it with bone manipulation. Manipulation of T1, T4 is specific for the lungs and bronchi. If you don't know that, look on a spinal reflex chart and you can see which spinal levels interject different organs. Simple. So T1 through T4. There's a diathermy. If you've never seen one before, they're amazing. You can use them to treat tuberculosis. You can use them to treat pneumonia. You can treat asthma. It's amazing. So get a diathermy or rent one. And support systems. I like botanicals I have what I call a Breathe Easy tonic with Ma Wong in it. And that sucker dilates bronchioles open like that. It's great. So I use that as an adjunct, but you can use botanical. The adrenal glands are always fatigued in asthmatics. You must support the adrenal glands so they can produce their own cortisol. That's what you have to do. You got to get the adrenals to produce their own cortisol. So I'm going to blast through this, use homeopathics, use glandulars. Bowen therapy, I always do these bronchial moves, the Bowen therapy, many ways to address this. The Breathe Easy tonic I told you about, I have people do that instead of inhalers. If it's not working, then use your inhaler. But let's see if we can get you onto the botanicals, and then it's easier to support your healing process. This is blood photography. I don't know if you guys have seen this kind of work before. This is actually a cancer patient of mine, a breast cancer patient years ago. Her initial blood photo was on the left. That doesn't look so hot. Her final photo after working with her and free of cancer, it was 6 months later, is on the right. My dad said, the whole purpose of everything you do is to repair the blood. If the blood is not strong, you cannot heal. So everything that person eats, everything they drink, everything they breathe has to support that blood to be strong. You cannot possibly poison the body back to health. You cannot put a toxin in the body and expect it to be healthier. It doesn't work that way. So allopathy are poisons. They're poisons with specific side effects that we use as pharmacological effects. But they're poisons, and just keep that in mind. Even an aspirin is a poison. You cannot poison the body back to health. I know I'm past time, but this is what naturopathy is. Read it in your notes. And nature always heals and is always constant, and it will always be there for you.
What a great way to end. It's really interesting. Thank you, Dr. Dick Cronenberg, and all of you for incredible presentations. And they really show the range along the therapeutic order, our spectrum, not only in therapies, but also in evaluation. There's different clinical pearls that they shared about how they scale up and move through force. And we're trying to externalize that more. What I did notice in ending, Tish, is level 7 wasn't there. So my question is, when you send a patient to the ER or tell them to go to the ER, do you tell your patients to use a nebulizer at home, like some of the other doctors? And how do you know that you want them to do that?
Yes, I'll tell them to use their nebulizer, and, it's when they're in distress. They usually know when they can't breathe, so use it.
Okay, great. So I just wanted to know if level 7 was in your...
Number 7 was not there.
It's only there when needed, right? Okay, so thank you. And now's the time for you. First of all, big round of applause for all our presenters. So this was a good live codification process of pulling different pieces of our body of knowledge together. So I'd like to invite you to come up and ask the questions that have come up for you, share your thoughts, particularly about how we move through force. Vitalism is really at the heart of it. A question, one of the key elements of vitalism and the V's is how we manage force, not suppress the healing power and process of nature, but how, not what do we use, but how do we know what to use, okay? So come on up to the open mic, share your thoughts.
You said, thank you to all you guys. You've influenced my career tremendously, and just one comment, as someone who started riding with the ambulance, I say the emergency room's job is to make sure you don't die today, and they're awesome at it. And then they discharge the patient to their dysfunction. And that's where our clinics pick up, and we're the best at. But I brought a wonderful MD colleague to Bastyr, and we were touring the clinic, and I was disappointed to see the new poster on the therapeutic order. And the thing that hit me, Tish really touched on, which is, why have we removed the bold statement of remove obstacle to cure, or if we want to sound a little more humble, remove obstacle to healing as our first step on the posters that are in the clinics? So,
since I'm at Bastyr, I think they put the heading, establish the conditions for health, and that would be a subset, but that'd be a great thing to elevate on the poster. I think it was just editing.
And my thought is just, if you forget to screen something like apnea or something like that, and for the student brain, it didn't hit me as pungent as if you don't take care of those roots and the obstacles to poisoning those roots, everything else doesn't roll out, and we get a little happy with supplements and diet alone.
That's great feedback. Yeah.
Thanks very much for that awesome panel. I really enjoyed it. My question is, I treat really chronically ill patients, and I've been in practice for a long time. And you touched on identifying the healing crisis. I wondered if you could talk about this a bit more, because even after 21 years, I still sometimes wonder, is this a flare-up of their condition? Is this a healing crisis? Just if you could elaborate a bit more on that, because I do those things. I do hydrotherapy. I recommend those things to my patients, but I think it's important to kind of differentiate between those two states of a flare-up and a healing crisis.
How many of you share that question? Just quick, look at that. Okay, fantastic. Great question.
So there were two very famous French doctors in the realm of immunology, MD, PhDs. They happen to be named Jerne. You should Google them. Jerne and Jerne, and they came up with something that I witnessed Dr. Bastyr practicing. I didn't understand what Dr. Bastyr was doing, and he didn't know anything about Jerne and Jerne, but they basically, if you look at the diagram over time, you start out with a low level of antigen, a low level of immunologic, a low level of response for whatever the condition is. That's called tolerance. And then over time, if the underlying conditions are not addressed, conditions for health subserve, over time, the response gets worse and worse and worse, and eventually it reaches a high point, which Jaron called hypersensitivity response, or you know, I call a healing crisis. What Bastyr did in situations like that was continue whatever the offending agent was, which seems bizarre, but then over time it goes to an other level, which is called immune tolerance. So that is basically my thought, that the healing crisis, there is such a thing. It's immunologically proven, at least in that realm.
Others? Yeah.
I'd like to add to that, give a little different perspective. In the case that I talked about, the 8-year-old girl, the 5-year-old girl, what I saw, and this is typical, can follow slightly different patterns, but the patient.
Louder, yeah.
The patient has a certain level of illness when they come to see you. You begin treatment. Presumably, hopefully, what you start to see is they get better and better and better. We are guided in this by Herring's laws. I look for improvement in the more deep or important organs first, such as breathing. As the patient improves, they feel better, they tell me they're doing better, the various measurements are better, but they may, like in this particular case, then she had an acute bronchitis. In my mind, that was a healing response, partly because this time she didn't get worse, she got better. She didn't go back to the hospital, she didn't have an acute breathing crisis. It was easy to get through that. So she went from this asthmatic state, better, better, better. Then she got sick, after which she was significantly better. I see that same basic pattern when I treat people with cancer or anything else. It manifests differently in every patient, more or less. Typically what I'll see is they'll feel better, better, better. They feel really good. Then they get sick, usually with a fever. Then I see this is a healing reaction. Now, if instead what I'm seeing is more critical things start getting worse, that's not a healing reaction. That's a disease reaction or disease
Thank
crisis.
you. Thank you very much. And we have the high sign. Those are great answers. We have 2 more questions. The lady in pink, you're welcome to ask your question too. But we're on the wrap. Little less time than we thought we had.
All right, I'll be quick. Mine is more just a comment and an observation of the spectrum of experience, that you all have the therapeutic order piece, but it's interesting that, Dr. Patterson, yours was laid out exactly all the way through, where, Dr. Dick Cronenberg, yours was, it was more blended in, and each year of experience as doctors, we grow and take on things that are a little bit more aggressive, and the things that we're comfortable treating are different for me now, 15 years into practice versus a year into practice versus 15 years from now. So I think I really was able to see that spectrum today, and it was really encouraging, and I hope for those who are newer in practice to look up to the people who have been in a while to keep with that mentorship.
Thank you so much. Great comment. Thank you.
Hi there. I wondered if you could comment a little bit about immunizations and given in to very young babies and how that affects asthma, and what you've done for that, as far as, because in my practice, almost every mother would say they'd had it since they were born. And I'd get them to talk about, oh yeah, it was after they had their first immunization at 2 months.
So this is a great question that could be a whole hour of response. We all know, right, folks? So if we can do a homeopathic level response, because we're on, just a brief pearl of wisdom from a couple of you. Relationship of immunization to asthma, very briefly. Brief comment.
It's a great question to end on, right?
It's our next talk.
I think for me, in terms of the sensitivity, I'm always looking at the immune function, if there's that hyperreactivity, and how do we help to support that through the pieces. I do look at homeopathy as well, but especially for any infants under 2, everything is in their GI functioning. So what do I do to support that, so that if they're going to continue down that path, how do I make sure their immune system is less hyperreactive? So I'm looking more at the immune function with that piece.
Great, thank you.
When you inject multiple toxins that are designed to generate an antigenic response into a tiny baby, what do you think is going to happen?
He's very relaxed about this topic,
Okay, you can
isn't he?
see I have an opinion on the subject.
Jared's suppressing his emotions.
But there are things you can do to reverse that. I use the homeopathic preparation and no-sode of the vaccine. I do hydrotherapy. I work in every way I can to detoxify that and to try and heal that immune disturbance. So.
And that child's adrenal glands are already suppressed. So don't forget the adrenals. They produce the cortisol that's going to heal ultimately. So give the baby glandulars, give the baby adrenotrophin. I'll say it, standard process, adrenotrophin, protomorphogen, rebuilds the glands.
Thank you. Any comment?
I think we're good.
Okay. Well, what a wonderful note to end on. We've got this, people. Low force is us, right? Thank you to our amazing panel members. This is our inheritance and our legacy. Let's do this.